Okay, Steve, I'm going to turn it to you. You can share your slides and the floor is yours.
All right. Hey, everybody. Thanks for joining today. We're going to talk about burnout, everyone's favorite topic when it comes to physicians and how they view their work. But we're actually going to look at it from a different angle than maybe you've talked about it and talk about the mismatches that fuel that from the person who did the most research on burnout, Christina Maslach. Just a brief shout out to some upcoming sessions for this series. We've got Dr. Sandy Mudge, Dr. Frank Batcha, and Dr. Raj Soni, each presenting some more aspects of how do we help our clinicians and other workers with their workspace and create supportive environments for them. So I hope that you'll look at those and tune in. Our objectives today are to talk about these 6 workplace factors, to describe the key concepts there, and really to discuss some potential solutions based on individual burnout profiles or situations. So I hope that we're going to have a great discussion today. And I was pretty excited last month. Both Chris and I were at a conference where we got to hear from Dr. Christina Maslach, who, when you have a burnout inventory named after you, kind of puts you up in the stratosphere in terms of superstars on this topic. And back in 1997, Christina Maslach wrote this book, The Truth About Burnout. And I snapped up every single copy used on Amazon I could find and started handing it out like candy around Boise. And really to get this conversation going, most of you have already seen her definition of burnout, which is a syndrome of depersonalization, emotional exhaustion, and low personal accomplishment, which eventually leads to decreased effectiveness at work. She's been studying this for the last 50 years, and she started not in healthcare, but on caring professions. So all of you social workers and counselors in the room today, she started with you because we recognize this is a pervasive issue. And I like to use a lot of metaphors. I'm a communications major, and so the way I picture this is that personal accomplishment in the workspace is always fighting against emotional exhaustion and depersonalization. And whichever one of these wins, if personal accomplishment is lower and the other two are higher, it's going to get pulled over in a burnout. Whereas personal accomplishment can also pull, and it can create this deep sense of engagement and meaning in work. And so I think the conceptualization there of the tug of war, this isn't something you can solve. It's something that you have to manage. And so when you think about the MBI, the Maslach Burnout Inventory, it's not a diagnostic tool. It's just an opportunity to get a glimpse of where people are at. And the one thing that Christine Maslach did recently, her latest book, 2022, The Burnout Challenge, I love the title, the subtitle, Managing People's Relationship with Jobs. And in 2019, the WHO gave a definition, not a diagnostic definition, but a syndrome definition, conceptualizing burnout as resulting from chronic workplace stress that has not been successfully managed. And so when I think about this and think about how Christina Maslach pictures this as a relationship problem, burnout best conceptualized as a relationship problem. The issue is with the fit or the match between the person and the job. That starts popping all sorts of metaphors to me. How many of us think of some relationships perhaps that started out great, people that you know, or maybe some of your own, they started out great, but over time, the relationship, the fit, the match kind of changed. And suddenly, what used to work doesn't work anymore. Or maybe even that relationship never should have started in the first place. It was unhealthy to begin with because it wasn't a good match. And so we think about relationships and think about how they're bi-directional, they're dynamic, that they change over time. And this is really how we need to think about burnout and people's relationships with their job, thinking of it in terms of those kind of dynamics. Now, over the past decade, we've seen this fundamental shift in thinking around physician burnout and burnout in general. What started out as a person only focus, which was, well, who's got burnout and what do they need to do to fix it? And solutions were really focused on individual things like resilience building and better coping mechanisms. Maybe we could coach them or counsel them, those types of things. And we really moved along. Certainly in this series, we've begun to show that we're focused on organizational level solutions. And we're asking not just individuals who are burnout, but in aggregate, who's burnout, what department, what service lines. And then we're asking, what's the environment that's causing this in the first place? I think of a coal miner, for example, that might have black lung disease. We wouldn't say, how come you're still coughing? You need to exercise more. No, we would look at this as a systemic environmental issue that we need to fix something about the workplace that is causing not just one person, but a whole host of people to have the same issue. And certainly that's what managers and leaders and CEOs and other C-suite leaders need to think about is what do they, as the people who drive the workplace, have control over that they can change for employees. Again, the WHO, we've seen this picture before, the social determinants of health. We know that it wasn't just about clinical care. We used to think, oh, access to care, access to care. Well, it's not just access to care. It's all the other things around a person's access to care that also really drive their health. And so we take a look at what are the potential determinants of physician well-being or other clinicians. We don't have exact percentages here. This is just kind of a faux pie chart. We do know this, 80% of burnout is caused by organizational situations. And that's based on what Dr. Colin West, who's a lead researcher at Mayo Clinic, has said in personal correspondence. Dr. West has traveled here to Idaho 2 or 3 times now and is a great friend of ours. So we've been able to have this conversation with him. And so think about that. Think about how this fundamental shift has shifted from the individual's problem to the organization problem. And really it goes up to higher levels, regulatory, industry pressures, medical cultural pressures. Those all have an effect on the organization, but the organization is what we're talking about today. What does it have control over to fix the work environment so that it can reduce and prevent burnout? And some of that is going to be about improving job matches and fit between people and their job. Now, it doesn't mean that the individual has no responsibility. In fact, we should best conceptualize this, that well-being is a shared responsibility of the employee and employer. Just like a person's diet, exercise, and smoking, it does affect their health. It's not just only about environmental factors. So too, for individuals, there are things that they need to do as well. And sometimes that's giving them help mechanisms and coaching and those kind of things. So as we get into this, we're going to deep dive into the areas of work life in the next, I don't even know, 15 minutes now. So we're going to go quick. And what you see here is Dr. Maslach joined up with Michael Leiter over the past 40 years, and they began to define what are the areas of work life that have the most impact on a person's burnout. And they recognize these aren't the only places of work life, but these are the 6 areas: workload, control, community, rewards, fairness, and values. And these can all be measured individually. And when we do that, we can see opportunities emerging for changes that leadership can make. Now, the one thing that we need to recognize, these are highly interrelated factors. For example, someone who has an unsustainable workload because they just can't control the pace of work or the interruptions of the day, that's going to affect their sense of community, right? They don't have as much time on the job to build relationships that are an important part of what make a workplace function well together. Or perhaps a person's misalignment between their expectation of being honored or rewarded, that's going to affect their sense of fairness and their alignment with the organization's values and their own. And so those are going to contribute potentially to burnout. The other factor we need to recognize here is this, and Chris and I kind of had this little bit of an argument that we could tell you about at the coalition conference I was telling you earlier. And he said, where's leadership? Where's leadership in all this? Well, leadership is all over this, because I know Chris comes at this from a leadership perspective, and every single one of these areas are places that leadership has control and influence in. So I'm going to stop talking and let you just look at this slide and kind of take it in, thinking about your workspace and how it may or may not align with those. So just take a few minutes and look at that. Which gives me a chance to catch my breath and slow down. And I want you to think and pull up the chat. And in the chat, I want you to type match. And I want you to think of the places where you've worked, where you felt I would almost show up here, even if I didn't get paid, as long as my basic needs were met. And type what domain or what keyword would you say that's what made it an amazing fit, an amazing match. I loved working in that space. Go ahead and throw that into the chat so that everyone can see it with the word match in front of it. Well, I'm not seeing any come in, but I suspect that you guys have been matched well at some point. Think also, there we go, values, fairness, rewards, those spaces where you felt a deep sense of meaning and connection, psychological safety, community. Yeah, it's all over the map, and we all have different areas that are important to us: collaboration, control, working with others. So much of it's relationally based, isn't it? Now, I want you to think about the clinicians and the physicians that are in your workspace. Think about, of those 6 work areas, of the 6 top level words, which do you think physicians say that's the most important domain in terms of me feeling connected? Just put that in as a single word without anything in front of it. Which do the physicians and clinicians in your space? So I'm seeing control, 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 community values, control. Okay, control is coming up an awful lot, right? Because physicians have been trained to want autonomy. Well, the fact is, this was a trick question because every single physician has a different thing that's most important to them. Although we often hear about workload and control, the fact is this, that everybody has a different thing that presses on buttons that are important to them, not one size fits all. And so that's an important thing to take away from this. Another thing that Maslach did is that she and Leiter put these into 3 dimensions. They put workload and control into a capability dimension. Can I even do the job? Am I capable of doing the job based on the workload and the control I feel I have over that? Then there's the social dimension, comprised of community rewards, and the moral dimension in terms of fairness and values. Now, they also described what would an optimized workspace look like. And I think this is the kind of place that most human beings would want to work, right? Certainly I would. Sustainable workload, ample choice and control, not complete choice and control, although some of us might say that's, but ample choice and control. Supportive work community where we feel encouraged and honored by other people, gratifying recognition and rewards, norms of fairness, respect, social justice, well-aligned values, and meaningful work, right? And I think that our work as leaders or managers or those who just want to bring change, we have to look for ways to increase these spaces if we want to decrease burnout and disengagement. Christina Maslach says it this way: when workplaces are designed mostly for the economic bottom line, they may miss the mark on the human one. And that can actually be bad for the people who work within them. Yeah, and we've certainly seen that in healthcare, haven't we? Now, I'm not going to spend a lot of time on this, but it's a connection between these 6 areas of work life and the Maslach burnout inventory scores. And this is a conceptual kind of etiology, if you will, of burnout. And the point of this is that there's no direct relation except certainly between workload and exhaustion, although other factors here. But the point of this is that there may be some causality, but this is a complex thing. It's not like you can just tweak one thing and exhaustion or cynicism or efficacy gets fixed, right? These are complex interactions because they're people. So one thing that we need to do, and you certainly are going to have access to all these slides, is stop thinking only in burnout or in binary, rather. I have burnout people and I have not burnout people. And those are the engaged ones. And I want everyone to move over here. The fact is, in the studies that Maslach has done, is that they have profiled different people based on their MBI scores, their burnout inventory scores. Now, take a look at this. You can see that that engaged worker, the one that we want everyone to be functioning at, when they measure up to 3 low frequency and negative scores on the Maslow burnout inventory, you see that the areas of work life that the fit is high. And again, when I get to this, I'll just go to the next slide so it's a little bigger. When we are talking about this area here of the engaged worker, we're talking about fit, not necessarily high control, low control. It's about whether the expectation of what the employee has fits with their reality. And so you might have somebody working 50 hours a week, and that's going to crush one person, whereas another person's like 50 hours. I can do 50 hours in my sleep, right? And so it's really about the fit. So going back to this, you see that you have engaged workers and burnout workers. That's 3 high fidelity frequency negative scores rather. And then you've got inefficacy only on the MBI, cynicism only, depersonalization, or exhaustion on the MBI. And what they're showing is that when you see these types of MBI profiles, you can match where the average areas of work-life scores come in. So let's just talk really briefly about a couple of these. Okay, here's an ineffective worker, a personal accomplishment low. Again, these are average scores. their workload, it's a good fit. They must have a good sense of how much workload there are, but all these other things are kind of marking low. So this might be a sense of, yeah, they're just not really engaged with the job very much in terms of how they feel, whether they're effective at that job or not. An overextended worker, their exhaustion level is really based on workload. It's a huge issue, right? It's probably caused a little bit by lack of control, but it bleeds right into that fairness issue. This isn't fair. I have to do all this work. I'm just exhausted by this. Or you might have a disengaged employee who workload's not out of that. It's not terrible, right? It's acceptable, but everything else is in complete dissonance. Community, values, fairness, all those types of things. And so you see that this is where depersonalization and cynicism are high, even though the workload is acceptable. That's still going to lead to a person that is disengaged. And then, of course, burnout, complete mismatch in the majority of areas. So those profiles may be useful for you as you look around your workspace or as you survey people. Now, one thing that Maslach encourages us is we should move beyond thinking that good job matches are when people just have the physical or the mental ability to do the job. We need to think in terms of psychological fit as well. And that means not only thinking about training and education or making sure that they have good stress reduction techniques or work-life balance. It really is, how do we maximize psychological fit for people to the positions that they're in so that it better fits on them. Think in terms of like ergonomics, for example. If I was in the Coast Guard and they gave me a life vest that was 2 sizes too small, that would be a bad fit. That means that I wouldn't feel safe in my job to do. And so one of the areas that she talks about is how if we can get to these, up here in yellow, competence, autonomy, belongingness, positive emotions, fairness, and meaning, if we can increase those and make more of those happy faces, then the psychological safety in those units, in those workspaces is going to be much better. And how is that going to affect patient care and overall satisfaction and serving of customers? This can be a lot better workspace for the kind of outcomes that most managers and CEOs want to achieve. Now, I want to be clear that when we talk about psychological safety, we're not saying that that's the sum total of those 6 happy faces. McKinsey defines psychological safety as being in a situation where you can, say something that's different from what everyone else is saying or do something different and still be okay with that. You're not going to be shamed. You're not going to be bullied or harassed, those types of things. A little bit different concept, but nevertheless, psychological safety is part of what makes a good psychological fit. All right, we're coming in for a landing. Everyone's amazed on the team that I could do this in 20 minutes, right? What are the potential opportunities? Organizational level. First, you got to measure. You don't know anything if you're sitting in the C-suite, if you're in the leadership area and you haven't done any type of survey. And there's several different types of survey. Of course, Maslach and Leiter have their areas of work-life survey. And then there's the free AMA organizational biopsy tool. Chris and Katie Schneider helped showcase that in the last couple of presentations this summer. And those are going to help identify systemic issues, right? Where are the places that leadership can really make a difference? Here's where the sweet spot is. The potential opportunities at the service line or at that unit level, really at the ground level. This is where there's an opportunity to look and even ask managers and clinic directors, what comes up in meetings? Where are you hearing of these 6 workplace areas? There might be some mismatch in aggregate or individually, and then using those to help guide some of the action. And when it comes to solutions, don't try to attack everything at once. Go for the lowest hanging fruit that you can implement, and that's going to help accelerate and feel some momentum as you begin to make changes. And of course, it's still a balance between the 80% and the 20% of what an individual can do. And so we do want to engage with individuals about where they are mismatched in terms of what their own expectations are and the reality of their workspace. So one of the key things is that we don't put the blame on employees. We don't put the onus on them to fix their problem. We're really looking as managers and leaders going, how can we get this match a little bit better? Let's explore some solutions better. And you can use the profiles. You certainly wouldn't want to depend on them, but you can use those to be curious. And so now we have a chance to have a conversation. And so if you have questions, you can go ahead and pose them there. And certainly this is an opportunity for us to begin to interact with the rest of our panel today.
You did it, Steve. Thank you. Yeah, let's open it up for some Q&A. And I think Hongyana is going to place the link for the resources that you referenced from Chris's presentation a couple of weeks ago. What questions do we have? Thanks, Chris.
Not a question. I'll just make a comment while people are thinking of their questions, but I really appreciate in your presentation, Steve, this sort of divergence from polarized thinking that it's either environment or individual or only environment. And it's kind of a blend basically. And also how it gets really nuanced at the individual level. And just as an example of that, I've reviewed massive amounts of burnout and well-being data. And I always find it interesting how I can find a particular specialty or service line and have a group of individuals where, let's say, 40% of them, 50% of them say that they're extremely burned out. And then another 40% are totally fine. Same job, same environment, which is super interesting. This shows how nuanced it is, that it's not as cut and dried as, the same environment is reacted to differently depending on the person and the individual, their skills, their capacity, their personality type, and so on.
Sure. And Chris, you've looked at a lot of data in aggregate, both at the system level as well as at individual department level. Can you talk about maybe some of the ways that you've approached zeroing in on, okay, we got something in aggregate going on in this department, and how you approach that?
Yeah, when we're at St. Luke's, we're using the AMA organizational biopsy, which is pretty comprehensive. It has a lot of questions around demographics, which gets you down to the service line, specialty level. And we're asking some of the typical questions around burnout, but also the drivers of burnout, everything from the EHR to leadership engagement. So we have lots of data and we can actually see it at a granular level. And that just allows us to have those conversations with those service line or unit leaders and say, hey, your team, you're a little bit of an outlier here in something, and we can show some of the correlational analysis and maybe based on those discussions kind of pinpoint what groups we need to focus on and what aspects of the environment might be driving and then the higher degree of burnout. And oftentimes we find it is won't be surprised for me to say this, but oftentimes it's leadership, but it's oftentimes centers around the feeling valued, autonomy, control of the environment, and just practice efficiency. These things just keep coming up over and over again.
Camille, I saw your hands up. Thanks, Camille.
Yes, I will lower my hand. Great talk, Steve. I'm curious for you or Chris, in terms of how you communicate that this is a philosophy, right? Overall, as an organization, so that people know that that's the base expectation, right? Is this safety and this fit and working together and figuring this out. How what's the philosophy in terms of incorporating that into the culture overtly so everyone knows that that is a difference, that this is an approach or this is happening, so it's not a contributing factor to someone feeling unsupported or unsafe.
Chris, you want to talk a little bit about just culture and the work that St. Luke's has done there? I think that's a good example of really proactive communication.
Yeah, we've done a lot around that. We've implemented some pretty comprehensive education programs around that, and we have a sort of decision tree that we use to identify areas of concern. And I think linking this to well-being is interesting. I think well-being and psychological safety are definitely linked, as we saw from your presentation. We've tried to show the linkage of burnout to psychological safety, and not only psychological safety, but medical errors, safety events, and so on. But in terms of the communication of how you get sort of adoption of this, I was going to respond to one of your panel questions, so I'll just give you a sneak preview. Is I think being able to convince the C-suite that there is a high cost of attrition, right? Showing them the data on what it costs to replace a physician or APP or healthcare worker, and then showing the research that links that with the drivers of well-being that you just kind of presented us. And that kind of provides this financial argument for starting to think about well-being and the drivers of well-being, opens the door. And from that point, that just, you can propose other things, whether it's a department for well-being. I mean, easily, if you could prevent one person from leaving the organization or two, that would offset the FTE cost for like 1 or 2 people to do this sort of work. So I think getting the data in front of them and showing a financial business case for paying attention to burnout and these drivers of well-being would be the first step.
So, Chris, is it something, for instance, that is in the application process as people onboard, that it's discussed? Is it part of that interview process, or even from before someone joining the workforce?
Yeah, I mean, we, Dr. Schneider and I, we do have a space in our onboarding program where when folks are coming in, we give them an overview of what we're doing at St. Luke's for them, what the expectations are, what our leaders are doing. So we give them and what all the resources. So we try to catch them right when they're coming into the organization, let them know that, hey, we're driving a culture of well-being here, and we have a part, your leaders have a part, and you have a part as well. We set expectations for both leaders, us, and our providers on, whether it's modeling well-being or taking advantage of the offerings. Before they get in, we still have some work to do around that, but we're currently thinking about how we're going to, I think if you're doing a lot of well-being work in your organization and you're showing results, that's a good attractor from a recruiting standpoint. And if there's a way you can package all that up and put it into a recruiting package, I think that would be beneficial.
Brian, you want to go ahead and share?
Sure. Steve, thanks. Excellent deep dive into that issue. And I loved your example about the coal miner and the black lung, and only if you'd exercise more, you'd quit coughing. Sometimes, when we look ergonomically in the workplace, we can see those obvious changes that need to be made or things that can be implemented. This is not as visible, but I'm just wondering, how do we think more ergonomically on this side of the equation? Is it a survey? Is it, being more active? I think one of your slides had, the obvious things of more huddles and being more connected, but how do we think more ergonomically in this space?
Yeah. I want to defer to the rest of the panel on this first, because you guys are the ones working right in the systems. Well, I think at the very least, as others think about how they might respond, is as a manager, as a leader, just looking at those 6 areas and thinking in terms of what they have responsibility for and what they might even expect people would say. How are people doing in terms of workload? How are people doing in terms of control? I mean, just a leader taking time to do that and postulating what they think it is, and then going and asking people, how's the workload? How's your control factor here, right? I mean, that alone, as a leadership shift in thinking, rather than, oh, they need to figure this out, but me thinking about that as a leader, that alone would get some really great conversations going to start with. Others?
Yeah, I think that's great. I think to answer that question, I'd say a culture is important, right? And so if this becomes a cultural change in the organization, then everyone is set with that expectation. So just like Chris said, it has to start in the C-suite, right? But it doesn't end in the C-suite, right? The C-suite filters down to what our case report is going to be about, is going to filter down to the dyads, right? Which are like the manager level people. And then even at the nursing, at the nursing and physician leadership area, I think that's how you really push this through, is that this becomes an expectation in your organization. And so Chris talked about orientation for physicians and what the expectations of physicians, but that same thing has to happen with the managers, right? Like, this is our expectation. You're going to be graded on your promotion is going to be determined on how well you're taking care of everyone underneath you. And I'm assuming that Luke's is doing that.
There's also some basic behavioral principles that are important as well, right? If you ask for feedback and there's that whole control and feeling like you have input, but you don't do anything with it, so that you can't just take surveys and you can't just wonder what's going on. If there's no action, it will inadvertently make things, worse if people feel that their organization is just going through the motions and not actually enacting any of their ideas.
Yeah, that kind of touches on what I was going to talk about too. I'm curious because Chris, you were saying that, and Steve, thank you for a wonderful presentation. You were saying that, and we even saw this in the chat, that autonomy and control, leadership also, but autonomy and control specifically are something that come up a lot. So how does at a system level, how do you address that in ways that physicians feel more comfortable in their workplace, like there's a better fit?
That for me, Deb.
Anyone really,
Yeah.
but you're in
Yeah.
that role, but anyone else is fine too. Mhm.
Yeah, that's a good question. This year we had a question in our organizational biopsy, a new question around whether they had autonomy, control over that which they're accountable for. And it's one of those questions where it needs to be unpacked. It could mean so many things. Like some things you can have control over, some you can't. And so we have a lot of work to do around unpacking what that means. But based on the work that we've been doing and some of the research that we've done on physician and APP or provider engagement, we know that involvement in decision making is a critical driver of engagement and well-being and having that sense of autonomy. So autonomy isn't necessarily being able to do whatever you want in your clinic, but it's that being able to influence decisions that are being made at a senior level. And what we've seen, our data shows that some of our leaders are doing things around this, and it's correlating with their low levels of burnout. And they're doing things like creating shared governance structures and committees and councils where, hey, we're going to bring these leaders together, representatives from the provider community, talk about key decisions that we haven't made already, right? You have a chance to be involved in decisions rather than, hey, we made a decision, now we want your input because we're implementing it next week. That's very poor change leadership. So we're starting to see that, and I think it's working. Now, obviously, there's a lot of nuances with autonomy and the clinical level, and be able to make decisions and so on. But that's one thing that we're seeing that's making a difference.
Certainly, one of the challenges in the healthcare environment is the fact that we all feel so much is driven outside of what we actually have control of in the organization, right? Reimbursement rates, prior authorization paperwork, regulatory issues, all of these things that drive the decisions that are kind of beyond even the CEO. So, this question, I remember years ago talking with Dr. Jim Souza from St. Luke's and showing, just talking about these obstacles. He goes, oh, it's so discouraging to hear that it's beyond me. And I'm thinking, Jim, you're the leader of one of the, nation's large health systems. You need to get together with the other leaders of nation's large health systems and push upwards against these things. That's the only way change is going to be made. Individual physician is not going to be able to do it, and an individual CEO is not going to be able to do it. We all have the ability to push upwards at the next level of change. And unless there's a banding together, then those things aren't ever going to change.
Great. Deb, do you want to wrap this one up and then we'll transition to our case?
I just think it's really interesting, as you guys are talking, this idea of, how do we talk to each other? Like Camille was saying, asking people's opinions. And like you were saying, Chris, making sure you're asking those questions before a decision has been made. So it seems like there's an opportunity to start exploring, how do we talk to each other? What are ways that would be constructive, where it's respectful to each other, but also allows us to have a sense of autonomy, a sense of control, involvement in our organization. So there's skin in the game. We feel like we're part of it, sense of belonging.
Thank you. So let's, very in the same vein here, we're going to transition to today's case. So Steve is going to give us the background, and then we can open up for those questions, conversation, recommendations about this particular situation.
Yeah.
Thanks, Steve.
So Cindy is the administrative dyad with Dr. Dumore over the hospital medical staff, which is part of a faith-based hospital system. And since the end of the COVID pandemic, she's been monitoring an alarming trend of departures at clinical staff at all levels from the department, with turnover approaching 10% each year. This is twice the rate as nearby hospitals. And despite this, patient satisfaction scores and medical outcomes are good. Wait times are average, and medical staff in place are very devoted to their jobs. Retention rates have seen a slight increase in the past year. Planning for an upcoming meeting with the CEO to discuss these trends, the two are looking back over a few years worth of exit interviews and have made the following observations. Older employees are retiring not only before age 65, but some as young as their mid-50s. These include some highly experienced nurses and physicians. Comments from these seem to center around the recent change to a new EHR after only a few years of being with a different EHR. Many must use pajama time in the evening to finish their patient notes and at the same time managing out-of-control inboxes. Others cite the pandemic as a key factor, including lack of appropriate PPE, constantly changing guidelines, and being asked to take a 10% pay cut while they were working harder than ever in their careers. Some said there was no time in the day to be human like the old days. Cindy recalls at least one highly specialized surgeon they had recruited who left after only a year, saying, "I never guessed I'd be serving so many Medicare patients and get paid so little for it." Mid-career departures, they note, tended to be those employees with challenging family issues and parents who in challenging families and parents, and they need to have more flexible schedules to deal with those challenges. Cindy recalls several employees who floated ideas about opening hours in the evenings or Saturday mornings so they could flex their own schedules, and that would also serve patients better. Administration said, no, too complicated to manage. Cindy also recalls one of the NPs who left who was a great asset to the team. He had proposed doing some departmental barbecues to get to know other families. System denied funds or designated staff time for this. Others requested more MA coverage or even experimenting with scribes to see if it would help decrease clerical work. And then many early career departures where RNs and MAs said wages were not as competitive as other healthcare employers in the area. But even more recently, some who left cited the hospital system lack of robust response to confusion created by state policies around reproductive health. They stated specifically that it feels like the hospital doesn't have our back nor our patients, and it needs to keep up with the times. While they can't do anything about the departed employees, Cindy and Dr. Dumore want to bend the intent to leave and the turnover rate down. They don't know if current employees feel the same way as the others, or these are just one-off complaints. With so many different reasons cited, they're having trouble putting down any actionable ideas before they meet with the CEO. So considering the 6 areas of work life that we covered, workload, control, community, rewards, fairness, and values, and the burnout profiles we talked about, how might you counsel Cindy and Dr. Dumore as they assess the situation in front of them with the feedback they've collected? What are some organizational, unit, and individual opportunities that present themselves?
Thanks, Chris. Let's start with you. And if there have any clarifying questions, and then we'll move into those recommendations. So Chris and then Mark.
Sure. Yeah, I mean, first, Steve, I think you adeptly crafted this case study to touch on a lot of those drivers purposely, which is great. Made our job a little bit easier. I think I kind of talked about this earlier is, I'll probably provide a business case that shows the cost of attrition. And I would link that to the research linking attrition, likelihood to leave with burnout and all those drivers. And there's ample research out there now. And, if, tapping into their business acumen, that would provide a good discussion to move forward. What are we going to do with this? Can we formally start going down this pathway or embarking on formalized well-being improvement work based on this data? And once you crack that door open, I mean, it could be anything. It could be just one person, and then you just get into the playbook. Let's measure it. I didn't see that there was any measurement going on necessarily, so definitely would want to measure the burnout and all those drivers so that you can get that data down at the granular level. Then you can start seeing what's really going on, and then going on that more nuanced approach where you might have very individualized proposed interventions at a specialty level or even individual level. And then you might have some system-wide commonalities that you focus on. But really, I would just start with that business justification and business case, which is a financial one. And if they're paying attention, I think they would bite that lead, and that would open up the door for other work.
Thanks, Mark.
Yeah. I want to share something in just a minute, Hung-Yang, if you want to put that up. So I don't know if you knew this, Steve, when you made this case, and this is a made-up case, right? So, but there was an article that just came out in JAMA, and that was actually shared by the IMA like yesterday. I think it came out in the IMA, looking at the early burnout in physicians. Are you able to pull that up for me, Hung-Yen? Just open up that thing just so I can. I think there's some pretty amazing numbers in there real quick. But I will say, this is going to be a problem. This case you presented will be a problem. I agree 100% with what Chris said, but again, I think this is a problem until the culture changes in the institution, right? So stop right there. I'm just going to jump back to this real quick. The physician specialty with the high, so this study showed, I think it was 150,000 physicians. I can't remember. It was a big number of physicians that they interviewed. And 40% of the physicians were planning to leave medicine or leave their position early before retirement. So even people who were at 60 were planning to leave before they were at 65. But the big number in this was like the number of people who were in their mid-career who were planning to leave medicine because of burnout issues. And it was a pretty high number, like 30%. But if you look at internal medicine is a very high number, family medicine is a very high number of people who are planning to leave medicine. These are people who want to leave medicine prior to retirement, which I think was like this. These numbers blew me away. So you could take that down. It's in the chat if you guys want to take a look at the study yourself, but it was a pretty amazing numbers there. But anyway, getting back to what I was saying is like, this whole thing doesn't change. You know, if you blame this on an individual manager, this doesn't change until the culture changes. So that's sort of the unknown in this is like, what's the culture of the institution? Like, is the institution institution that believes in physician wellness or caregiver wellness, and then has programs like we've heard from Chris that St. Luke's has to sort of make that alive within the organization. If that's true, then yeah, this manager needs to be held accountable for implementing changes. But if this is not a culture of the institution, it's going to be very hard on an individual basis as an individual manager to make changes. Not that you can't make, you know, incremental improvements, but I think until the C-suite and the people above you buy into the fact that, hey, this is important, then there's not going to be a lot of opportunity for change. And I think, again, that goes back to what Chris just shared with us about maybe the economic argument wins the day in the C-suite, right? With the CFO and the CEO. But it's going to be hard to change things unless it's believed up there.
Those are great numbers. And I think as a female physician, as a mom, you know, what the flexibility of our systems has been a major issue, that the ability to or inability of a system to flex to retain people and keep people, especially if you ever want to show up to be a volunteer at school, or you ever need to, you know, cover pickups or drop-offs, or want to have a flex, be able to go from full-time to part-time, or maybe do some evening hours, or something like that seems to be chronically lacking in our healthcare system, that we don't seem to be able to figure out how to do that in some facile, easy way to make it so that people can live life and work and kind of combine that joy and productivity. I don't know why chronically healthcare struggles so much with that issue.
Yeah, I think that's such an important point. And Mark, those numbers are just they kind of blow you away when you look at that and you think about that. And we actually are seeing that out in practice. How many people are leaving the field? And one of the things that I see, Steve, in your case study that seems consistent with early workers, mid workers, and later workers is a sense of being valued. You know, in each of those cases, you know, they come up with creative ideas, they're shot down. You know, their pay is not really what it should be. And like you're saying, Camille, you know, people come up with these ideas in order to be able to flex like this, but they're told, no way, you can't do that. We don't have money for barbecues even. Um, and then, you know, certainly being, you know, the whole way people were paid less during COVID, all of these things reflect, you know, how well people are valued. I wonder what you guys think about that. That just seems like a thread through all of that.
I love Christina Mazak's quote on this, that workspaces that are designed mostly for the bottom line are bad for the people who work in them. And that gets to this issue of what's the primary. Obviously, workspaces aren't designed just to have a great old time and party all the time, right? They are to get things done. But even, you know, it's funny, as Chris started, he said, I would go to them first and make the case for financial. Well, that might work with some health systems. If this is a faith-based system, we might actually go and appeal to the organizational values, because a missions-based hospital is going to be possibly pretty keyed into those values even more than the financial values. So part of the issue is finding out what's important in terms of mismatches, what's important at the highest level, and going with those arguments in mind. And I do want to kind of get back to these areas of work-life mismatch. When you look at all of those different variables, are you seeing some of the mismatches either between the organization and the individuals, and how would you call those out? Not being valued in many different ways. What else do you guys see in terms of mismatches that would lead to burnout, early retirement, or leaving the organization?
I wanted to elevate a question in the chat. Does cultural change perhaps apply to even larger system of healthcare in general, and even bigger to our national workplace? Lots of compelling data pointing to worker desire for shorter work weeks to give more balance to life. Do you want to kick that off, Stephen, and see if others
I'm
have?
going to go with Brian on this one, because Brian works with lots of different hospitals and in this workspace in terms of advocacy. What are your thoughts there?
No, I think it is a broader question nationally. You know, I've had an opportunity to work in a number of different industries, so to speak, and whether it's government or whether it's research or now in the healthcare space, I think there is a growing desire. I think about each of those areas that you mentioned, and workload, control, community, rewards, fairness, and value, and those are all going to weigh differently for different people. So it really is a community that we have in the workplace. To Camille's point, I'm past the time of needing to go to a sixth grade band concert. So that's not important to me anymore. And in fact, if there's something here at the office that needs to be done and somebody else needs to go to that sixth grade band concert, I'm happy to step in and fill that role. So from a workload standpoint, in this community, there are people that are willing to acknowledge and accept those priorities of their fellow community members. But to Stephen's question in the chat, I think we have to be more sensitive to the growing need across the country, nationally, to find a better work-life balance. It is different than it was 10 years ago, pre-COVID, and those kinds of things. So we need an awakening in this country to help address this, not just for burnout in healthcare, but in all workforces.
Thanks, Mark.
Yeah, I think in this context, I'd give a shout out to Deb and the Action Collaborative and the work that you guys were doing on prior authorizations in the context of physician wellness. And to see now that that has been picked up on a federal, so there's now federal interest in reducing the burden of prior authorization. I think all of that is such a great model. And I think what we don't realize is like a lot of that push came in this local medical environment. It just shows what's possible when people work together to solve this problem. So I don't know, Deb, if you want to give a quick overview of what of the trajectory of that.
Yeah, thank you. Again, it goes back to Brian's point. It's the community that comes together and the way that we can come together around a table, how we speak with each other, how we involve each other, how we respect each other. And we found that, people that we thought were going to have very different opinions than we did actually had a lot in common. Pretty much all the payers and the insurance people and the payers and the insurance bureau and the systems and the physicians all thought that we needed prior authorization reform. And so that was kind of an eye-opening time where we thought, oh, there really is common ground. But I do think it comes back to kind of bringing the community together, talking to each other in ways that are respectful, and looking for ways forward that we can walk, together with. And then there's just amazing opportunities that arise. It's a village.
Oh, and Deb, can you mention what's going on at the federal level now as a result? I mean, some
Yeah.
of your work.
I mean, I think that this is really being taken up on the federal level to start to and I'm not sure it's because of our Action Collaborative, but I think that we were working in concert. A lot of local communities were doing this work, and then that's picked up by the AMA and by the Office of the National Coordinator, and there's legislation coming out now that's really working hard at increasing this transparency, at getting physicians prior authorization data at time of service, at decreasing some of the burden there for physicians. So it's really wonderful how, you like you say, Mark, you start in the local communities, and also Brian mentioned this as well. And then there's many different local communities, and they're all doing this work, and then it just becomes a bigger umbrella for us. Yeah.
Oops. Thanks, Charlie.
Steve, I was just curious, does it tend to be higher rates of burnout in for-profit healthcare systems versus not-for-profits?
That's a great question. I don't know the answer to that. Chris, you're tapped into the research. Have you seen anything on this?
I haven't, but I would like to.
I know certainly there has been research into burnout levels between those who are employed physicians and those who are independent physicians, those who work for themselves, basically, especially at that lowest level of solo and small practice. Burnout levels are much lower. Now, workload can tend to be really high. I mean, I know some independent physicians here who are working 80 hours a week, but they get to set the fairness and the rewards. They get to establish community. Their values are constant because they are the workplace, right? And so it goes to show that one of these areas can be completely out of whack, but it can be mitigated by these other areas that are maybe more important to a person. And so burnout does tend to be lower for those who drive their own autonomy and decision making around. It doesn't mean that prior authorization that's beyond their ability to control doesn't impact their work, but there is a sense that they have more control because they drive their workspace. So really it gets down to people walking into that workspace and feeling, do I get to contribute to the way things go around here, or am I just a cog? Because if I'm just a cog, then it's just like any other industry. Think 100 years ago at the turn of the century of the 20th century, and how this was about labor unions and work hours and safety and all the other issues, right? And so we see that these things are cyclical, that when people are sucked up into the cog of industry, whatever the industry that is, that's really what drives burnout. So I don't know. We'll have to look around and see on the nonprofit or for-profit hospital question. It's a great question. So I'll just read Jessica's question. Tying this to the last session, are there places where we frontline workers can push on the external systems that seem to be making all of us feel out of control in our work and the care we have to provide, acknowledging the workspace impacts? It feels like most folks in healthcare I know are also struggling there. Yeah. So what are some areas that our panel might mention about where frontline workers can push on external systems to make change? One more minute left too. So one quick question. Anyone?
Well, again, I would refer to the Action Collaborative. I think that's a great model of getting people together to solve even simple issue. I'm not saying prior auth is a simple issue, but you could pick a simpler issue and get people together in the same room and have a discussion about how that one thing is affecting you. I think if you just think about like even in your IT, I remember Colin West telling a story about their EHR and associated with burnout. And they had found out that for an outpatient physician to order a flu vaccine for one of their patients took 20 clicks. So it was 20 clicks to get a flu vaccine, which seemed ridiculous. And that was in the Mayo system. And so they worked with IT to take away some of those clicks and take that burden away from people. So I think there's little things like this that, add to your frustration during the day and make you feel bad, that you could potentially have some control over and work on as a community within your office space to fix.
Deb, I'm wondering if there's a way in which we could get information about that collaborative and how folks can be involved, if you could put that in the chat.
I sure will try to do it in time for,
Okay.
I know it's 1:30. Let me look it up real quick and get you a link.
You can email it to me and we can put information on
Perfect.
our website where you've entered this site will be one of those resources that is offered. So look
And
there.
truly, it really, as Mark said, it's an open group. It's for anyone who wants to join. And we just work off of the idea of relationships. So we just ask people to invite people that they know to come to the table. And sometimes some of the most unlikely people come together and we learn things about, how we're all feeling about these issues. So we welcome all of you to come. We're actually working on several issues right now, prior authorization. We're working on the reproductive health issues. And then we're going to actually have a meeting soon on dealing with the language that's involved in applications and how sometimes that discourages physicians and other clinicians from addressing their mental health. So yeah, we'd love to have you. I'll get that information to Camille.
Steve, thank you. Steve put it in the chat, and we will
Oh,
also link
Steve,
it
you're
in
the
our
best.
resources.
You're faster than me.
Multi-screens.
Thank you.
Yeah. Thanks for a great conversation. Charlie, thanks for the words of wisdom in the chat at the end here. We're going to have this session series meet again Tuesday, September 17th from 12:30 to 1:30 Mountain Time. So we hope you can join us. Our presenter is Sandy Mudge, MD. She is from Full Circle Health. And the topic will be fostering resilience, creating supportive workplaces for peers. So we hope to see you September 17th to continue the conversation. Thank you so much. Take care.
Thanks, everyone.
Bye.